Cataracts. We've all heard of cataracts. Maybe you've had a cataract or you know someone who's had cataract and had surgery, but what exactly are they? And when do we need to worry? And when do we need to consider having a procedure done for cataracts? Well, to get all of those burning questions answered, definitely tune into this week's episode of the IQ Podcast when I'm going to be talking with my friend and colleague, Dr. Kira Manusis, who's a cataract and cornea specialist. So stay tuned. Eye on cataracts. Welcome, everyone, to another episode of the IQ Podcast, where you can gain insights into your vision health and brain health and raise your IQ. My name is Dr. Rani Banik. I'll be your host. And today I am so excited about today's topic because it's something that comes up all the time with my patients, which is cataracts. So we're going to be talking all about cataracts, what they are, what to do about them, what's the newest, the latest technology about cataracts. And I'm going to be inviting my special guest to join me. And we're so excited to have on the IQ Podcast this week, Dr. Kira Manusis, who's a friend and a colleague. Dr. Kira Manusis is an associate professor of ophthalmology at New York Eye and Ear Infirmary of Mount Sinai. She is a director of the Center of Refractive Solutions at New York Eye and Ear. She attended NYU School of Medicine, did her ophthalmology training at New York Eye and Ear, and went on to do a cornea and refractive surgery fellowship at Columbia University. Then she returned to New York Eye and Ear, where she's been faculty for many years, and she actively participates in resident education and fellow education in cornea and cataract surgery. Dr. Manusis specializes in both cornea and cataract, and she has real expertise in complex cataract surgery, lens implantation, including multifocal lens implants, as well as refractive surgical procedures, including LASIK and ICL implantation. So I'm so honored to have with us today Dr. Manusis. Welcome.
Thank you, Rani. Thank you for inviting me. It's really a pleasure and a privilege to join you.
Yeah, I've been looking forward to our conversation because I always learn so much from you, when I ask you questions about what you do, about, the latest technologies in cataract. It's just mind-blowing, like what's going on. And I learned so much. So I'm excited for you to share your wealth of information with everyone. And I always love to start by asking my guests how they got interested in doing what they do. So how is it that you first got interested in ophthalmology and then specifically being a specialist in cornea and cataract?
Yeah, thanks for that. So going to medical school, I was really clueless, to be honest. I had this optimistic view about cures, and I wanted to become actually a pediatric oncologist, believe it or not. I wanted to cure the pediatric world of cancer. And then the reality hit when I went to med school and the sadness around this profession, and I just couldn't follow through. So I started looking for a happier field, somewhere where you can have this sort of almost instant gratification at the same time. It was very visual and complex and hands-on. And two of the subspecialties where you can have this instant gratification, it's such a happy event, is ophthalmology and specifically cataract surgery and refractive procedures, as well as OBGYN, more specifically obstetrics, where you deliver babies, right? And it's this amazing, happy occasion, and it's instant gratification for the team and for the parents. And so I looked more into ophthalmology, and I actually loved it. I loved the complexity. I loved the fact that it was so visual, that if you knew your stuff and you did the exam, you could actually figure out what's happening with the patient. And then you can go in and do your surgery. And then the next day you take the patch off, and there's nothing like it, right? You probably agree. There's really nothing like it when the patient says, oh my God, I haven't seen my daughter, my family, my son, in a decade, in 2 decades. I mean, those are obviously extremes, but for the most part, it's really this amazing, gratifying process.
Yeah, I know, in other fields, like you were mentioning, you may not get that instant gratification, but when patients can get not just their vision restored, but their life restored, their functionality restored, it really is quite a gift. Being able to do that, and especially with a procedure that's relatively straightforward. For example, a cataract surgery or refractive surgery. Of course, it requires a lot of skill and experience, but the procedure itself doesn't take very long, but that it has such a lasting impact. So let's talk now specifically about cataracts. A big question I get is, what is it? Like I've heard that I have a cataract. I have no idea really what it is. Can you explain? So can you just share with us, like, very basic ground up approach. Like, what is it? What happens in the eye?
I actually brought an eye model, which I actually use with my patients because there's nothing like seeing it. Telling someone they have cataract is so abstract, and I see you have an eye model behind you also. But I always have one in my office, and I always sit in front of a patient and I just show them the eye and I say, well, look, this is the eye and this is the clear lens that you have. And we all have a lens that allows us to focus on the back of the eye. And if it's clear, we could actually see through it nicely. The patient can see through it nicely. But then as we get older, the lens starts getting cloudy, and in extreme cases, it can turn completely opaque. And so the view into the eye is obstructed, and our view into seeing the retina is obstructed, so patients start seeing blurry. And so this process is actually an aging process. It starts anywhere after 50, closer to 60. And it can take years, decades sometimes. People could say, well, they start experiencing symptoms of blurry vision or halos around lights at night or difficulty reading or pretty much anything that involves using your sight in your daily life. And in some people, for instance, some people are born with cataract. Some people have genetic predisposition and they can have cataracts in their 30s or 40s. But I would say mostly it's something that starts in everyone closer to 60. It can take years to decades. And there's nothing to do for it. You go for your yearly checkups. Your doctor may tell you, look, you're developing cataracts, but if you have no visual complaints, we'll continue watching you. And again, it's not pathology. It's just part of an aging process, something we'll have to go through.
Yeah. So, two things. First of all, for those of you who are listening to the podcast, I strongly encourage you to watch it if you can. Switch over to YouTube and you can see the eye model that Dr. Manusis is showing. You can see where the cataract sits in the eye. So it's also important to kind of visualize and conceptualize like where in the eye, because the eye is very complex. It sits in a particular location. And I always love to explain, the second thing I wanted to share is that I always love to explain to my patients, it's like, think of the lens inside the eye like a window. When we're young, that window is clear, it's transparent. But as we get older, that window becomes dirty with age. It becomes opaque and it becomes harder to see out of that window. So that's similar to what happens when a cataract develops as we get older. Now, I know you mentioned that it happens with age. So does everyone get a cataract if they live long enough?
So everyone gets a cataract if we live long enough. And in this day and age, I think last time I checked, the average age at which people get cataract surgery in the United States is about 67, 68. It's on the younger side, but we're in the United States. We're lucky we have access to medical care. And if you have any type of visual complaints, you can see a provider and they can explain to you how we take it out. We'll talk a little bit about that later. And you have access to doing your surgery whenever you're bothered by your vision. Obviously, in other parts of the world where access to medical care is not as accessible, patients tend to wait longer, where they're essentially blind from cataracts. And it's actually one of the most common causes of blindness in the world.
And reversible causes of blindness, right? Some causes of blindness are not reversible, but this is something where even if someone has the most advanced stage cataract, surgery can still be successful as long as the rest of the eye is healthy and people can have their sight restored, which is really incredible. You mentioned that the average age is 67 for surgery, but do you have any statistics on what's the average age at which a cataract actually begins? Do we have any data on that?
So the data shows that the lens starts undergoing changes even in the early 50s. And people notice first that their glasses prescription may change. For example, you may go from being nearsighted to farsighted and the reverse. And that's the first indication that the lens starts changing shape. It may not be getting cloudy yet, but the process has started. And in the early 60s, we start seeing the first changes, opacity changes in the lens. They may not be visually significant, but they begin early
So
60s.
you're saying from an examination standpoint, we see it, 50s, 60s. Patients, though, may not notice it right away, right?
I have patients who come in and 85 and they have no idea. The process of aging in their lens for some reason takes a little longer, and they'll come in and they'll still see extremely well. They'll be 20/20 without complaints. And then you'll tell them, well, you have a cataract, and they'll be totally shocked and surprised.
Yeah. So, cataracts may affect central vision, so you may still see well on the chart, but the other things that they affect include contrast and color. And so some of those changes are so slow that people don't realize it. They're, developing over years or decades. So I've had patients who didn't know that their vision was so affected until they had their cataract surgery. And then they say, oh my God, I feel like I see in Technicolor now. Right? I'm sure you've heard that too, right? So, like these slow
Exactly.
changes, people may not notice day to day, but when you take the cataract out, it makes a huge difference in
Huge difference.
brightness, especially night vision,
Night
right?
vision of people tell me, oh my God, I thought, my walls were, warmer color of, let's say, pinkish. And then in reality, they're whitish, like people will
Mhm.
decorate their apartments and all of a sudden they notice that they picked the wrong colors. I mean, you don't
Yeah,
realize it, but it's because
you
it
don't
takes
realize.
years, you don't realize it. Yeah.
Yeah. So, we've talked about age as a risk factor for cataract, and yes, everyone gets it. No matter how healthy you live, no matter how healthy you eat, whatever you're doing lifestyle wise, if you live long enough, you're going to get a cataract. Bottom line, unfortunately. But the good news is there are ways to treat it. But what are some other risk factors for cataract? Like what are some other in
The
your
one of the
practice? Like
most
what are the
common
biggest
risk
risk
factors is diabetes. So diabetics, especially uncontrolled diabetes, where the sugar is not well controlled, tend to develop cataracts a little earlier. So it's something to talk about. Sometimes my patients will come in and ask me, well, last week I saw clearer than this week, or my vision tends to fluctuate. And some of it has to do with the fact that the sugar is not controlled. And months to years of uncontrolled sugar can push that lens into a territory where you develop cataracts sooner than you otherwise would. Also, I should say that someone who's developed trauma, for example, or had eye surgery, which is a form of trauma, can develop cataracts a little earlier.
factor?
Genetics is one of the risk factors for diabetes. If you have someone in your family who's had cataracts at an earlier age, you may be one of those people who will develop cataracts earlier. So those are some of the more common risk factors for cataract formation. Some of the others may include inflammation in the eye, such as uveitis, or certain procedures that you've undergone, like laser procedures in the eye. But those, I would say, are the most common causes of developing cataracts earlier.
Now, what about light exposure? A lot of people are concerned, whether they spend a lot of time outdoors in the sun or maybe even like blue light from our screens. What's the data say about that? The risk of light damage.
So I always tell patients to wear UV protection outside, and that's to protect the entire eye, right? Your retina, as well as your lens. It has been shown that those that have significant UV exposure can develop cataracts a little sooner. Um, so we do encourage people to wear UV protection outside. Um, Exposure to your screens has not been shown actually to
Mhm.
increase the cataract formation or cause them to form earlier. It does
And
cause
actually, I
fatigue.
always tell my patients if blue light were related to vision damage, we would be having an epidemic right now, right? Because we're all
Exactly.
on our screens, kids, adults,
Exactly.
and it hasn't
Exactly.
happened, luckily, right? So it's okay. Like, it's not going to cause you permanent damage, maybe short-term damage, but not permanent damage.
I mean, we
Uh,
know that it causes fatigue, especially if you have reduced vision from cataracts. You will be more fatigued while using screens for a prolonged period of time, but it's not one of those risk factors where you have to worry about limiting your time on screen.
mhm. Yeah, I want to just share, you were mentioning like UV exposure and some studies. There was, I believe it was the Chesapeake Bay fishermen study. Was that the one where they
Yep.
they looked at they did eye exams on fishermen who were out in the sun all day long for years and decades, and they looked at their rates of cataract and macular degeneration. And interestingly, macular degeneration was not a higher risk, but yes, they did have a higher risk for cataract formation.
Yes.
So
Those
that's
who
one
are
of the
out and
key
about
studies.
without protection. Yes.
Yeah, yeah. Now, what about kids? Like, what are some, you mentioned that even kids can get cataracts. Like, aside from genetics, what are some other risk factors for cataracts in kids?
So there are some kids who are born with cataracts, and there is some genetic predisposition there. And obviously, it's still a reversible cause of blindness. Babies do get cataract surgery. Sometimes it's hard to fathom, but babies do get cataract surgery, and thank God for our advances, and we can, get them to see well. But kids can develop cataracts either from trauma, which is one of the most common causes. they get into a fight, they get hit in the eye, they can develop cataracts. Those kids do have any other systemic conditions that can predispose them to cataracts. Some of the metabolic conditions that can predispose them to cataracts, diabetes being one of them.
Mm-hmm.
So we do see occasionally kids with cataracts, but there's usually some sort of either predisposition or trauma.
Mm-hmm. And some children do have genetic, not just a genetic predisposition, but sometimes
Genetic
spontaneous
mutation.
genetic
Yeah.
mutations, which cause metabolic disturbances that can lead to cataracts. So it's pretty rare, right? As I would think. Welcome back, everyone, to the IQ podcast. We're chatting today with Dr. Kira Manusis, who's an expert in cataract and cornea surgery. So, Dr. Manusis, I wanted to ask you next. I'm sure people are wondering, what's the best way to manage cataracts? I mean, can you just monitor them? Like, how do you decide on when surgery may be appropriate versus observation?
So usually I'll talk to my patients and ask them a list of basic questions. What do you think about your vision? Can you go through your daily life and not think about how well you see, because you see so well, you don't even notice it? Is your vision impacting your activities of daily living? And we can go through the list. Do you spend any time on the computer, or do you like to drive for a prolonged period of time, or do you read for a prolonged period of time? How well do you see? Do you use glasses? Do you not use glasses? Do you feel like you're straining? Do you find it difficult to read in low light conditions? And so we'll go through all of these questions to try to figure out how bothersome cataracts are to our patients. And we'll do a full eye exam. And depending on a combination of those two, what I see on my exam and what are the complaints of our patients, we'll figure out if those cataracts deserve addressing, or do we just watch them. If the patient says, you know what, I see great, I do an eye exam, and I don't really see a significant cataract, we just watch them.
Mm-hmm.
We don't do anything about them. I encourage UV protection, but other than that, obviously healthy diet, but other than that, there's really nothing to do. And it's important, especially after the age of 50, to have your yearly checkups.
Mm-hmm.
To
So
monitor.
basically, what you're saying is not everyone with a cataract needs to rush into any procedure or anything.
Not at all. Not at all.
Mhm. Yeah, I
And
think that's a misconception. Like people, they hear the word cataract, like oh my God, I've been diagnosed with a cataract. What do I do? It really depends on your symptoms. Like what you were saying, those questions are so important. So ask yourself those questions. How does it impact my life? Can I still do all those things I need to do? And if so, tell your doctor and have a frank discussion. And there's no need to rush into surgery, right?
Exactly. And some patients will tell me, you know what, I could see everything and I'm completely fine. There's nothing to do. But you know what? I really can't see to drive. That's the only thing that bothers me. Do I need surgery? And
Mm-hmm.
this comes up all the time, because you could say, well, they could tell you that they're fine, but if they spend significant amount of time driving and it really impacts their life, then yes, we should address it. There's really no reason to ignore it or get yourself in a situation where it's no longer safe to drive or limit
Mm-hmm.
yourself in any way. So if a situation is such that someone really can't participate in some activities of daily life because they're impacted by their vision, then we could say, well, you know what, let's talk about surgery. But other than that, it's okay to watch.
Mm-hmm. Do you know if there's like a tool online, like some kind of cataract screener that's been validated to help decide, when is it the right time for surgery? Like, is there like a list of screening questions like what you were asking earlier?
I think it's pretty individual. Usually I tell patients, think about 5 most common activities that you do every day and think about how well you can do them. And if
Mm-hmm.
you could do those 5 most common activities, because they're different for everyone, 5 of your
Yes.
most common activities, just think about what they are and can you do them well? Is your sight
Mm-hmm.
impacting them? And if the
Mm-hmm.
answer is no to 4 out of 5, then we watch them. But if
Mm-hmm.
every year there's less and less of those activities that you can do well and the sight, is affecting you, then we should address it surgically.
Yeah, that's a great way to have that conversation. I typically have asked my patients, like, can you still drive? Can you drive at night? Can you look at your phone? But asking them to just, decide which are the 5 top things that they do and can they still do them comfortably? That's really a great tip. So thank you for that. So let's now talk a little bit more about cataract surgery. It's been around for decades. What is the process? Like, just walk us through, Dr. Manusis, like the most basic of all cataract surgeries, not the complex ones, but the basic ones. What happens?
So I think we should sort of take a step back and go into your visit. How should you prepare for your visit? If you think you've been told you have cataracts, or you think you may have cataracts after listening to this podcast, what should you do and how should you prepare for your doctor's visit? I think it's important to think about all these things we just discussed, about all these activities, and have them in the back of your mind. Think about what are the two top activities that you would like to do, especially that you would like to do without glasses, so that when you go and have that discussion with your physician at your visit, it's easier to select a lens that will help you in your daily life, sort of for the rest of your life. So thinking about it in the back of your mind, thinking about prior records you may have in going for that visit. So when I see someone for the first time in my office, there's a lot of testing that you would undergo that can help prepare you for cataract surgery. And one of those tests is the measurement for a lens implant. So just to give you an example, with this model eye, we take out your cataract and then we put in a clear plastic implant into its place, just where your natural lens used to sit. So it's the measurements for this implant that we take in the office. And so you've gone through all of this testing, and we talk about your activities of daily living, and you select those activities that are important for you, where you would like to depend on glasses less, for example. And we look at all that testing, and then we have a discussion. Yes, you would do surgery. Once we decide that those activities are impacting your daily life, we move on to discuss surgery. The procedure is generally short, anywhere from 10 to 30 minutes. It's under local anesthesia, so you're pretty much awake. You do get a little sedative. I call it happy juice. So you're a little bit more relaxed and not stressed about the procedure. But most of the time we do like you awake, because if you fall asleep and then you wake up thinking you're on the beach somewhere, you may get startled and wake up and move.
Yeah. The other thing is I've actually had patients when they fall asleep during surgery and they start to snore. And then their whole head becomes like a moving target, right? So with their snoring. So it's best, I think it's best to have patients slightly, comfortable, but not asleep.
Exactly. And you don't feel anything. You don't see the blades coming towards your eye. People always say, oh my God, you're going to be inside my eye and I'm going to see it, I'm going to feel it. You really don't see anything. You see a bright light, you'll feel some water on your eye. Occasionally you may feel some pressure, but really it's a painless procedure. After the surgery, you may get either a clear shield or a patch, depending on your surgeon, and you're good to go. It's ambulatory, and you generally see your surgeon either later that day or the next day to go over your instructions.
Okay.
So
Can
all
you
in all,
share
it's really easy process.
Yeah. I'm just going to backtrack just a little bit. Can you share, like, how is the cataract taken out? Like, what's the process? Is it laser? Is it something else, some other technology for patients who may not be familiar?
So the cataract is actually broken in the eye using energy, and it's taken out through a tiny little incision. And that's what really makes it so quick and painless, and the rehabilitation is so quick, is because we make a tiny little incision. It's like 2 millimeters. And we use a source of energy to break up that lens inside the eye. And the energy can come either from ultrasound or laser. Ultrasound, like you mentioned, we've been doing for decades, probably 60 plus years. Obviously, the technology has evolved. And that energy is used to break up the lens, and then we sort of aspirate it out of the eye. And once the lens is removed out of the eye, into that same spot, it's like a little pocket, we put in an intraocular lens implant. And that implant helps us focus the information to the back of the eye, just like your natural lens would, except that this lens is clear. The second source of energy that we can use is a laser. The laser is newer technology, about 15 to 20 years old. And what the laser does is actually can create all the incisions, can break up the lens inside the eye, which is fantastic. You could see the entire eye on screen, and the laser is super precise and accurate and can make all the openings inside the eye and actually break up the lens into little pieces to make the work of the surgeon a little easier. So the surgeon can just go in and remove the pieces.
Now, how do you choose whether you're going to use the ultrasound energy or laser? Do you use a combination of both?
So I'm able to use both. I usually try to discuss both options with my patients and give them a choice. I tell my patients this: look, we have these two ways to do this. You can have either or, right? Provided that they can have either or. There are some patients who, for example, cannot have a laser because their pupil is really tiny and they don't dilate well. But for the most part, most patients can have either or. And I'll tell them, well, you can have either or. And if it's a routine case or routine surgery, you'll do well either way. But for
Hmm.
example, if it's a really mature, really dense cataract, or there's very little space in the eye where you could put your instruments, creating some crowding, or you may have some other diseases of your cornea that can predispose you to corneal swelling. In those cases, laser actually can make a difference in rehabilitation and how quickly you see after surgery.
Hmm. So, aside from the instance of small pupil, like why else would you not do a laser on everyone? What's the limitation?
Unfortunately, laser is not covered by insurance in this country. And so
Hmm.
it's an out of pocket expense. If it wasn't, I'm sure everyone would decide to have laser, and
Yes.
it wouldn't be even a point of discussion. But in this
Do you think
country,
it
there
ever
is,
will be a covered, covered procedure, laser
I
for
think,
cataract
I think
surgery?
eventually it'll become routine and it'll be a covered procedure. I think so.
Okay, that's good to
Um,
hear. Good to hear. But for
and
as of
because
now, it's a choice, right? And it's
right
a
now it's a
discussion you
choice,
should have with
exactly.
your doctor. Yeah, and the cost, yes, it does play a role for some patients. Whether they may be able to have a laser or not. So there's just so much we could talk about when it comes to the technology of cataract surgery. But one thing I just want to just briefly touch upon in the last few minutes we have together, Dr. Manusis, is you mentioned you put an implant in the eye. You have to do measurements ahead of time to decide which implant. Like, tell us a little bit more about that process, choosing the implant.
So the conversation generally goes like this. So we have these, I usually tell patients, give me all the activities you like to do. So we talked about those 5 activities that I usually tell them, think about those 5 activities you like to do. What are the activities that you like to do most without glasses? And this part comes up because whenever we put in a plastic lens in the eye, we could reduce someone's dependence on glasses. One example I can give, for example, someone is extremely nearsighted and they have to wear these thick glasses. And sometimes patients tell me, oh my God, I've worn them since I was 5 years old. I don't even see myself without them. So, what we can do is we could take that prescription almost and build it into the implant. And
Hmm.
that person who's had glasses their entire life can all of a sudden take them off and walk around without glasses. So that's just
Hmm.
one example, but essentially you can pick pretty much any activity. And if you feel that you would like to reduce your dependence on glasses, you can choose an implant that can do that. Typically, there's two large categories of implants that we discuss. One set of implants is called a monofocal lens implant, and it tends to give you clear vision at just one distance. So, just to simplify it, we live in the world of three distances. It's usually far, intermediate, which is your computer, and near, which is up close. And a single vision or monofocal implant can give you clear vision at just one of those. So that means for the other two, you have to wear glasses. And most often, people do choose to gravitate towards one of those implants. You get amazing quality of vision, but yes, you have to wear glasses sometimes. They do reduce your dependence on glasses, but you still have to wear glasses sometimes. And the
Hmm.
second group of implants are multifocal implants, and those implants tend to reduce your dependence on glasses more. And so they all give you distance and some near, depending on the implant. So we'll have
Hmm.
a discussion. Let's say someone will say, you know what, for me, it's most important to play golf, and that's all I care about. And I just want to see distance. I don't care if I wear reading glasses. And it's important to have that in depth conversation to figure out what is important for that patient, right? There are
Hmm.
some patients who tell me, you know what, I was never able to see up close. And if you can give that to me, this is what I want to do. You know, I want to spend
Hmm.
time reading my book, reading my laptop, spending time indoors. That's most important to me. And we
Hmm.
focus on doing that.
So it's a very individualized
Very
decision.
individualized, very
Yes.
individualized.
And so the second type of implant, it's not for everyone. It depends on your eye and whether you're a candidate or not and your needs, but the cost comes up again, right? So there's that question. So talk to us a little bit about that. Like, is it covered? Is it not covered? What's kind of the financial aspect of things here?
So if you come to me and you say, I would do whatever it takes. I would really like to have the least dependence on glasses possible. Then we focus on the second group of implants. They're called multifocal implants. Um, they do reduce your quality of vision a little bit because they do reduce your contrast sensitivity because they stretch that curve and they stretch the ability for you to see at multiple distances. And you have to have a relatively healthy eye to get one of those implants. Now, once we've decided that that's something that's important for you and your eye is healthy enough to do well with one of those implants, then we discuss each and one particular type of implant that will fit your lifestyle because there's a number of them. But
Mhm.
like you mentioned, one of the limiting factors is the cost, right? So someone will come in and they'd say, I'd love to have one of these, but I really can't afford one. I usually say one way to think about is the fact that this is an investment for life. You're really putting this lens once, and
Mhm.
it's supposed to serve you for the rest of your life. And thinking about how much eyewear costs these days, every time you get a new pair of glasses, sometimes it's half the fortune. So, and
Or
comparing these
contact
costs
lenses also, right?
for
So
contacts,
whether
that's
you
right,
wear glasses or contacts, you accumulate like the cost of contacts over years and the cleaning solutions and all of that. So,
all of that. And
mhm,
so, think about all of that and see if that's something that's within your budget. Obviously, cataract surgery will restore your vision and give you clarity of vision and impact your daily life no matter what. It's just whether you're going to be more or less dependent on glasses.
got it. Wow, that is such valuable information. Again, there's so many other questions I can ask you, but I'm just, trying to be mindful of your time and everyone's time. If there's one last kind of thought or piece of advice you'd like to leave our listeners with today, Dr. Manusis, what would that be? When it has to do with eye health specifically?
Follow Dr. Rani's book, where your UV protection, healthy diet, and see your eye care provider regularly.
Yeah, I totally second, third, fourth, all of that. It's so important for people to go see their eye doctor because, as you mentioned earlier, you may have a condition like a cataract and not know it. And you may think, oh, all is fine. I can see fine. I have no problems doing my daily activities, but there could be something brewing. So it's really, really important to see your eye doctor. Just like people get their dental checkups twice a year, they get their mammograms, their colonoscopies, you need to get your eye exam annually. So thank you for that. Now,
I
how can
second that.
people learn more about you, find you if they're interested, maybe becoming a patient or, you know, connecting with you? How can they learn more about you and your work?
So you can go on Mount Sinai's website, Mount Sinai Hospital in New York City, and you can look for me there, and all the contact information is on that site.
Wonderful. So we will include all of those links in the show notes, so you can check out Dr. Manusis and her work more. But I really, again, want to thank you for your time today, Dr. Manusis. It's been an enlightening conversation. I'm sure people learned so much. I know I definitely did. Again, thank you for being on the IQ podcast.
Thank you, Rani, for inviting me.
Absolutely. All right. I will see you all next time.